Welcome to the Hospice Education Series, Hospice and Hospital Care, presented by Cypress Basin Hospice. I'll be your guide today, Wes Smith. I'm an RN and Community Education Specialist with Cypress Basin Hospice. I've been with Cypress Basin for the last 11 years. Prior to that, I've worked on the med-surg floor, as well as spent many years in the nursing facilities. Let's get started with today's presentation on hospice and the hospital. End-of-life care. Cypress Basin Hospice is the community-owned and community-grown hospice since 1986, serving over 16 counties. We're the only nonprofit hospice in Northeast Texas. Cypress Basin was founded in 1986 by a group of local, civic-minded individuals who envisioned a community-centered organization that supported their friends and families through the difficult last weeks and months of an illness. We are CHAP accredited. CHAP is the Community Health Accreditation Program, similar to JACO or Joint Commission for hospitals. It holds hospice to a higher level of care than even the state holds hospice care to. We are also a Christian faith-based organization. We are committed to serving the Lord by caring for individuals touched by life-limiting illnesses, as well as grief and loss. Cypress Basin Hospice covers 16 counties of Northeast Texas, with offices in Paris, Sulphur Springs, and Mount Pleasant. Cypress Basin serves all. We serve Medicare, Medicaid, private insurance, private pay, charity care or non-funded care. Supportive charity care patients is done through donations and fundraisers that we have within the counties in which we serve. Care is also provided to all citizens of Northeast Texas. Serving all 16 counties, we serve ages from birth all the way to death. We're the only hospice in the area that services pediatrics. Cypress Basin has general inpatient contracts with the local hospitals, Titus Regional, Paris Regional, as well as the Christus Mother Francis Group in Sulphur Springs and in Winsboro. We also have contracts with UT Health in Pittsburgh. When do we usually hear the word hospice in our communities? Well, usually it's at church or at Bible study. We hear, "Y'all pray for Sister so-and-so. They've called in hospice." And everybody goes, "Oh, oh." So what do? We gather the casserole committee, start Pinteresting new recipes to try to feed multiple people, because we all know that we're going to have a funeral in the next 2 weeks. So we contact the funeral committee. Why do we do this? Well, we've been conditioned to believe that hospice is only for the end of days rather than the end of life. This myth has been perpetrated over and over and is the common accepted practice of many of those who even choose to use hospice at all. So why do we wait so late to utilize hospice care? Number one, we've believed the lie. We'll get to that in a minute. We think our doctor has to initiate the conversation. And we don't believe that this could be the end. Let's talk about end of life. When does the end actually begin? Great question. Let's do a little practical math. The average life expectancy is about 79 years old right now. 115 years is the longest recorded life in recent times. So, if you or someone you know is, let's say, 60 years old or older, then legitimately they are nearer to the end of their life than they are the beginning. Not too many 120-year-olds running around. Okay? So what is the lie? The lie in Genesis chapter 3, if you recall the story of the Bible in the garden, there was a snake and he told Eve, "If you eat of this tree, you will not surely die." Sure enough, they ate the tree, and here we are thousands of years later still believing that same old lie that you will not surely die. Well, it's not going to happen to me. It's not going to happen to my loved one. It's not going to happen to my patient because I'm a good nurse. I'm going to keep my patient alive, right? Well, that's our goal for sure. However, what's the truth? The same book. God told Adam and Eve, you eat of this tree, you will surely die. There's two certainties in this life. What are they? Death and taxes. Well, we know this is a certainty, and that's why we have so many safety precautions on everything, right? We know death is a certainty. Think about it. When was the last time you purchased a ladder or a car seat for a kid? There's 5,000 things on there that tell you not to do this, not to do that, do this, do that, or you will die. And yet, we don't believe that it's going to happen to us, right? Most of us are planners, right? Human beings have this ability to plan for things. We plan for events. Some of us have a 5-year plan. Some of us plan for weddings, plan for college, for ourselves or for others. Some of us even plan for retirement. And then there are some who have already planned their funerals. But most of us, we wait too late to plan for the end of life. We wouldn't plan a wedding the day or a week before the event. You wouldn't plan your retirement on the last day on your job. Go to work on a Thursday and go, you know what? I think I'm retiring tomorrow, and not have anything set up. We wouldn't do that. Why do we wait until the day of or the week before to plan for the second most important day of our life? As you see, we've got Elvis's tombstone here, and there's 2 dates: the day of his birth and the day of his death. No other dates. Those are the 2 most important dates of our lives. And yet, we don't plan for that second date very well. So most of us in healthcare have thought about at some point or another how we would like to die. And most folks, when they're asked, how would you like to die? Most of them will say either, I want to fall asleep and not wake up, right? So, sounds like a very pleasant way to die. Most hospice patients, that's exactly how they do die. Now, most of the time, they fall asleep maybe on a Tuesday, and they don't pass away till Thursday or Friday, maybe Saturday. They go into what we call a coma. But ultimately, to them, they went to sleep and didn't wake up. So, a very pleasant way to die. And again, that leads us right into our next topic of hospice. And what is it? Hospice is a philosophy of care. A lot of times people think that hospice is a place. It's not necessarily a place. There are some freestanding hospice units, but it's more of a special kind of care. It is palliative. It is comfort care. It's also holistic. We have an interdisciplinary team of social workers, chaplains, nurses, nurse aides, physicians, and it is very patient-centered care. We want that patient's goals to be met. And some of those goals are to be pain-free, to have reduced symptoms that come along with a life-limiting illness. Hospice is family-inclusive care. We bring those family members alongside and we teach them how to be effective caregivers. We treat their grief. We treat their caregiver burnout. We have things in place due to that holistic nature that we can help to reduce stress on a family that is potentially going through the most stressful time in their lives. Hospice is, of course, compassionate care. There are levels of care inside of the Medicare hospice benefit. Routine home care occurs wherever the patient lives, whether it's home, nursing facility, assisted living, even under a bridge, if that's where they happen to live and is their residence. Hospice can provide respite care, which is a 5-day stay at a nursing facility to give that caregiver relief from burnout, or if there's extenuating circumstances that the patient does not have a caregiver available, we can provide respite care for them at the nursing facility, where hospice pays for the room and board at that facility to meet the daily needs of that patient. Continuous care occurs wherever the patient lives. It is better named crisis care, so if there are out of control symptoms, the hospice can come and be at bedside for an extended period of time to be able to manage symptoms as long as those symptoms are out of control. General inpatient care occurs at a contracted hospital or skilled nursing facility where they have a 24-hour RN on site, or at an inpatient hospice facility. And general inpatient care is what we're going to talk about more today, in that we're going to be talking about hospice care in the hospital. Acute inpatient hospice care, or general inpatient, is care that's provided for acute symptoms that are not manageable at home or at a lower level of care. Also utilized for patients that need additional nursing support to develop their palliative plan of care to allow symptoms to become better managed prior to transfer to the patient's home, nursing home, or assisted living facility. Examples include, but are not limited to, uncontrolled pain, uncontrolled shortness of breath, uncontrolled anxiety, intractable nausea, vomiting, complex titration of medications that require close and frequent observation. So these symptoms have to be out of control. So if a patient is at home and they get into a pain crisis, and the medications that we have available to them at the house, or that we're available to get from the pharmacy and get to them to the house, is not managing them at home, we can bring them to the hospital to admit them GIP for IV pain medicines, or an IV drip or something to that effect if we need to do that, if we're not going to be able to get that medication available at home in a timely fashion. We can do those kinds of things. Same with shortness of breath. If somebody gets into a COPD exacerbation and is just completely short of breath and they need a BiPAP, but we don't have one available that the DME company can bring in an appropriate amount of time, we can have the patient brought GIP and get their breathing under control with medications, with BiPAP availability at the hospital, those kinds of things. Same with anxiety. If they need to be on an Ativan drip or something like that, we can bring them in to do that. During acute inpatient care at the hospital, the hospice provides arranging transportation to and from the hospital if the patient's already on service, obtaining physician orders for care and hospital administration approval for inpatient care, management of that plan of care. Hospice nurses make daily visits to assess the patient's response to the plan of care and potential need to alteration in plan of care to meet the patient's needs, and PRN visits are available as needs arise. Hospice nurse available to hospital staff for patient needs 24/7. Visits from other interdisciplinary team members per the patient's hospice plan of care, as well as payment to the hospital for room and board at the contracted rate. During GIP care, the hospital provides recognition and support of that patient's chosen end-of-life care. They provide the medications and medication administration, 24-hour nursing care for skilled care needs and all personal care needs, contacting the hospice for any changes in the patient condition, hospital staff patient family concerns, orders written without hospice staff awareness, or any orders for diagnostic tests or procedures prior to the test or a procedure being done. They also provide 24-hour visiting hours, for even including visits from children and occasional arranged pet visits. Teamwork. Communication. In order for the patient to receive the maximum benefit of care while on hospice and receiving care in a hospital, it is imperative that both the hospice staff and the hospital staff communicate. If one agency does not understand what the other agency is doing, and we don't ask questions to clarify the misunderstanding, then we allow confusion and mistrust to take seed and grow, which causes breakdown in communication, and the patient does not get the best of both worlds. Hospice in the hospital is a help to you, the nurse, as much as it is to the patient as well as to the family, because that patient who is experiencing uncontrolled symptoms and in the process of dying, this family member who's dealing with him, this may be their first time dealing with such an ordeal. It's the patient's probably the first time they've experienced going through the dying process. How many of you guys have already died? No. It's usually a one-time deal, right? So what better to have a bunch of experts who deal with the dying process on a daily basis to come in and help guide them through this process, through this change, to guide you guys as the nurses to have that expertise in palliative medicine right there at your fingertips. The other thing that I love about having hospice in the hospital is, for my days of working the floor, and you've got 6, 7, 8 patients, and you're running, trying to take care of these folks on the med-surg floor. Folks are coming back up from surgeries and all of those kinds of things. And then you've got that patient whose caregiver is just freaking out. They're on the light, and it's a hospice patient, and they're on the button, and they call, and you go, yes, and they say, she blinked. I think she's getting better. Can you come down here? And of course, what do? We go down there, we try to comfort them, we try to console them, but we know they're not getting better. When you've got that patient doing that, or that caregiver doing that, call that hospice. Say, hey, I need you to send me a chaplain. I need you to send me a social worker, send me a nurse up here, something, and get these people off my light for an hour. Give me a little bit of a break. We will run interference. We are good for that. Let us do that. Let us help you. How general inpatient often happens in reality. The patient is already admitted to the hospital for acute or chronic issue. The doctor, the PA, the NP notice patients declining rapidly and not responding to treatment. Hospice consult order is written. Case management's then notified. They speak to the patient, caregiver about hospice options. Patient caregiver chooses a hospice. Referral sent to the hospice for a consult or admit. Hospice arrives to discuss hospice care as well as to determine if patient meets general inpatient level of care. If so, orders are written for admission to hospice. New medications added for comfort. Patient is discharged from acute care stay at hospital and readmitted under hospice orders. If patient does not meet GIP level of care requirement, discussions had with the family, case management, to determine if patient is able to go home or to a nursing facility, and arrangements are made for hospice admission at new home location. A lot of times, we will see a patient who is declining rapidly. However, they are comfortable and there's no uncontrolled symptoms at the hospital. And so they don't meet general inpatient level of care if there's no out of control symptoms. Unfortunately, Medicare changed the rules a while back and made it that actively dying patients is not necessarily an inpatient level of care criteria. They must be exhibiting out of control symptoms that cannot be managed at a lower level of care. Common myths and misunderstandings about hospice. We talked about the first one. Hospice is end of days care. That is absolutely a myth. Hospice is end of life care. Medicare gives us 6 months to take care of these patients. They say the doctor has to write an order, or they have to make a statement that says the patient has, in their best medical opinion, 6 months or less. That is much longer than the last day of life or the last week of life. They have a lot more time to experience the hospice plan of care and get the support that they and their families need. Myth: hospice starves patients. We do not starve patients. We encourage patients to eat as long as they can possibly eat, and we encourage them to eat whatever they want to eat. We also encourage, but never force them to eat, because as end of life comes, Patients do, oftentimes, the satiety part of their brain kind of switches off and they're full. They don't have the feeling of hunger. Have you ever been sick and didn't feel good and you didn't want to eat because nothing tasted good? That happens, and it happens at end of life a lot of times. So we encourage our patients to eat as long as they can, as long as they want to. But once they get to where they can't, you really risk adding insult to injury by forcing food into somebody who's lost the ability to swallow well. Because then what are we going to have? Aspiration pneumonia. And aspiration pneumonia on top of stage 4 cancer is just rude and unnecessary. So we have a lot of education with our family members about encouraging patients to eat, but when they get to where they say they don't want it and they have trouble swallowing it, that's when we encourage them to encourage but not force. Myth: hospice uses medications in inappropriate amounts in order to hasten death. You've all heard it. Hospice gave Mama that morphine and she died. Right? Hospice is not in the business of euthanizing patients. That is illegal, unethical, and just not good business. Hospice does not euthanize patients. We use medications in appropriate amounts, in order to customize the plan of care to each individual. So if we have a 97-year-old female who weighs 86 pounds and she's never taken anything stronger than an aspirin in her life, when she comes to hospice and has a headache, we're not going to slam her with a dose of morphine. We're going to offer her Tylenol, offer her aspirin, one of those things that she's used in the past and is able to tolerate, and hopefully it's effective for her. And if we have to go up and titrate up, that's how we'll do it, slowly but surely. But no, we do not try to give those medications in inappropriate amounts in order to hasten death. Myth: hospice patients must have a DNR. Fact of the matter is, hospice cannot require DNR status as it is a violation of a patient's rights. So if a patient chooses to be a full code, patient's a full code. Now, in the event that they get to the point where their heart stops and CPR is initiated, they have effectively been discharged from service for seeking aggressive treatment. However, if they go and make it to the hospital and they get revived and decide they want to come back onto hospice, we would certainly take them back onto hospice. And again, we cannot require that they have DNR status as a condition of admission to hospice, because it is their right to choose hospice. It is their right to choose their code status. So who needs a hospice referral? That patient who is a frequent flyer, either to the emergency department or to your floor, has decreased appetite and unintentional weight loss, having increased frequency of medications or increase in dosage required to manage symptoms, or has, quote, maxed out therapeutic medication levels in order to manage symptoms. That person that's got uncontrolled angina that is taking the maximum dose of Imdur. That kind of person needs to have a hospice referral. That patient that comes in every Friday or Saturday with a COPD exacerbation or a CHF exacerbation because they're not able to manage themselves at home without oxygen, or that needs it, that doesn't have it, that needs it, or that's constantly having to have the fluid drained off. That person that needs to be on dialysis but doesn't want dialysis. Those kind of diagnoses need to think about hospice. That patient that's having increased skin breakdown, that nursing home patient that keeps coming in with a new wound and it's infected and UTIs constantly, and they're a dementia patient and having this over and over. Those patients that are just keep coming back to the hospital over and over with a chronic disease requiring that intervention. These guys, they may not be hospice appropriate yet, but they need that hospice consult so they know what their options are and where they're headed, and so they can get it at a timely fashion. Who else needs a hospice referral? That patient whose caregiver is stating things like, I can't get them to eat. I know if they would just eat something, they'd feel better and get over this. He just keeps falling. He's just so weak. I don't know what to do. I have to do everything for them now. He's just going downhill. I don't know how I can manage them at home like this. Okay? When you've got caregivers who are stressed out to the max, feeling this way, and when they verbalize this to you, they're not just trying to give you the facts so that you can document it in the note. They're actually reaching out for help when they say things like this. And hospice can be that help for them at home. And even if we are not able to admit them to hospice, we have referral sources of home health and those kinds of things that we could get them to in the event that hospice is not the first choice. We talked about medications a while ago, and we do use some high-powered medications, and let's talk about those for just a few minutes. We do use morphine for pain. We use it for shortness of breath, as well as for respiratory distress. We also use Zofran for nausea and vomiting. We've also used Phenergan, haloperidol, and some other medications, Compazine, those kinds of things for nausea and vomiting. We like to use methadone a lot of times for long-acting pain medicine, mainly because it is a long-acting opioid that can be crushed and maintain its long-acting properties. It also has less side effects than some of the other opioids. And once it's built up in the system, it's very effective for both neuropathic pain, bone pain, as well as regular somatic pain. We like to use lorazepam for anxiety and restlessness, as well as shortness of breath, and we use it alongside the morphine a lot of times to help with pain. We also, in some of our geriatrics, we have to switch over from the lorazepam to the alprazolam, the Xanax, because the lorazepam, people say they have an adverse reaction to, or they, quote, have an allergy to, but usually what they say is it makes me crazy, or makes them crazy. And so the Xanax seems to work a little bit better for those patients that the Ativan doesn't. We also use atropine eye drops for excessive secretions, or that death rattle. We put those under the tongue, not in the eyes, but under the tongue, and it helps to dry out those secretions that roll down the back of the throat once we've lost our gag reflex. And so it helps to dry that sound up so that it's not so Darth Vader-y sounding, if you will. And it gives more comfort to the family than it does the patient necessarily, but it is for its anticholinergic effects, it helps to dry up those secretions. Thank you guys so much for watching this video. I hope that it was helpful and you guys have a better understanding of how hospice works in the hospital. Please feel free to reach out to me at Cypress Basin Hospice. My name is Wes. I'm an RN and the Community Education Specialist. If you have questions or concerns, feel free to reach out to us anytime, 903-577-1510, or shoot me an email at marketing@cbhospice.org. Thank you and God bless you.